This episode is a bit of an experiment because we are venturing into a topic where there is not yet a clear-cut road for OT in value-based care contracting here in the United States. But as you'll hear, even though we are blazing a new trail, we can certainly leverage what has been learned by others. I honestly mused a lot on whether to pursue this topic because I like to give you all clear-cut paths to follow. But at the end of the day, I decided that this topic of looking logistically at our place in value-based care was just too important not to have. This conversation was recorded live on March 25th, 2025. So let's go ahead and dive in. Welcome to the OT Potential Podcast. Before we begin, I wanted to let you know that this podcast may qualify as continuing education for you. You are probably listening to this podcast on a free podcast platform, but to gain CEU credit, you will need to be a member of the OT Potential Club, our OT continuing education platform. After listening, you can log into the club to take a 5-question quiz, and we will generate a certificate for your time today. Okay, here we go.
Hello, everyone all around the world and on my screen. Welcome to the OT Potential Podcast. Today, we are going to be talking about value-based care contracts. I'll be hosting this discussion. My name is Alan Linick, and I am joined by a returning guest, first of all, from a podcast we've recently done, Dr. Carlin Reaume. Dr. Carlin Reaume is a pelvic floor therapist in Sacramento, California. Carlin launched Supported Mama Pelvic Floor Therapy in 2020 as a way to provide holistic support for women on the journey before, during, and after pregnancy. Carlin is also a board-certified lifestyle medicine professional.
Hi, Alan.
How you doing?
I'm great. I'm really excited about our conversation that we're going to have today. So thanks for having me.
Yeah, me too. I'm looking forward to it. I also caught something in a cup. What are you drinking? A coffee?
It is. It's a cold brew.
Amazing. That's
there we go.
When it spiked to like the 80s, not to brag, the 80-degree weather streak we've been having in California, I was like, cold brew is back.
That's right.
We are also joined by Dana, who I'm very excited to get to meet for the first time. Dana is a PT turned health policy professional currently employed at CVS. She is a value-based care and Medicare policy subject matter expert. Her goal is to enable and empower OT and PT pros to integrate into value-based care programs. Hello, Dana.
Hi, so happy to be here and chatting with OTs and about OT and value-based care. I don't get to do this on my day job.
You do or you don't?
I don't get to talk about therapy in my day job. So I love to talk about it on the off hours.
I can't wait to dive right into it. Actually, before we really kick our discussion off, I'm going to drop a quick link into the chat for our live watchers to a blog post that OT Potential put out a little bit ago describing value-based care and what it is and providing a glossary of terms. Some of that stuff probably will come up in our discussion. So if you need a refresher or you're curious, that's a great place to start. And also for our live listeners, watchers as well, don't hesitate to ask questions. We're curious about your thoughts and comments, and we are going to devote some time at the end of this webinar for Q&A. So we will revisit the questions that you post in the chat at the end of our discussion today. But I want to start with a really sort of simple question, and I'm going to direct this towards Carlin. Carlin, as a provider, what drew you to exploring value-based care? Why dive into, why crack this nut at all?
It's a great question, Alan. I have to say, when I listened to Dana's episode from earlier this year, from January, I think, of 2025, I just found myself really opening to possibilities and how my services and so many other OT areas of practice could be reaching people and making our services more accessible through this model. And I must admit, like I'm new to learning about it, and so I'm eager to have this conversation to dive into more of the details. I really recommend everybody listen to that January episode, so you have a strong foundation. But I just really started thinking about exciting possibilities, and especially, working in the maternal health space, I want people to have access to this care. And so, as an entrepreneur, I really, started feeling excited about ways I could innovate and connect and collaborate within my community related to this area of practice. So I think it's a model that has the potential to be spread throughout multiple specialty areas, areas where OTs are emerging, lifestyle medicine, prevention, wellness, in addition to more standard areas of practice. So excited to explore today.
Great. Yeah, I think it's interesting to look at this sort of like core concept of value-based care in terms of, yeah, we're gonna be gearing the treatment, or like gearing the care towards outcome, as opposed to, traditional like fee for service approach. And especially these days with the cost of everything, but especially medical care, and what an inhibitor for a lot of people the cost of medical care can have in terms of being accessible. I think it's a really, it's just cool to talk about, and I'm glad to have Dana here to talk a little bit about that. I mean, Dana, looking at Carlin's sort of specific practice as an example, how do you see value-based care sort of like plugging into and becoming part of the model here?
So I'm so happy again to be here and to talk about a topic I don't get to talk about as often, and really like to think through what opportunities there are in so many areas of medicine where we have an opportunity to do better and to contribute as OT, and as I'm a DPT, as PT professionals. And this is a great topic where value-based care really fits in. I'm going to kind of redefine value-based care for those who maybe didn't hear the first episode, and to make it really applicable here. So the term value-based care, we find, doesn't resonate with the public really well. United States of Care did a big study about this a couple of years ago, and they found that patient first care is really the term that resonates most. It's hard to move away from the term value-based care, but if you think patient first care, it's really a nice way to think about it. For the purposes of something like postpartum care, which we're going to talk about today, the opportunity in value is so high because we have issues with postpartum care in less than acceptable outcomes, insufficient access to care by new moms, and particularly impacting certain areas of the country, and certain minority populations that are particularly underserved, and particularly underserved in this particular area of healthcare. And it's an area where OTs can especially be part of a team that's caring for both mom and baby. So this will make a little bit more sense as we go along, but this episode of, birth and after and even before, this episode of time in a mom and baby's life is a special one where we can help craft new ways of accessing that care through OT and looking at it through the value-based lens. So just to take that one step further, whenever we have predictable episodes of care in any kind of condition, so care that is highly variable, can be very expensive, high cost to systems, to plan sponsors, to payers, where there's lack of access, and we have some incentive to change, right? Someone's feeling pain because of this. There's multiple stakeholders feeling pain here, and we have a solution that can be pitched to the right stakeholders. It means it's a fit for value. So postpartum care is just like square in there. I think one of the things we start with is really researching what's already being done and what's been started in the postpartum value-based care space. There's a couple of areas that are moving a little bit. particularly around Medicaid, where there's a terrible access problem, worse than in any other payer situation. But then also looking at employers, right? How do we create relationships and potential options for creative benefit design for employers, especially those employers that are that hire a lot of women and women of childbearing age, healthcare, right? Education, some of retail, some of those areas where plan sponsors are looking for creative benefit design. Those are going to be another area where we can take this OT untapped resource and partner and create a solution.
Gotcha. So how would one go about looking for these value-based opportunities? Like if I'm doing my own thing, I'm out there trying to, and it's strange too because I'm going to digress off my own question that I haven't finished asking. I feel like it's sometimes feels strange to have to quantify a lot of this stuff by cost because at the end of the day, for most OTs, and I imagine for most medical professionals in general, the dollars aren't the main drive to doing this work.
Mm-hmm.
So I think it's interesting to reframe the sort of mindset there towards linking more cleanly the value or the. I'm trying to get away from saying value-based care so many times because you just said
The
not
VBC,
to.
it's quicker.
Yeah,
No,
but just attributing or like gearing the cost analysis towards the outcome delivery as opposed to whatever traditional models already exist. So how does one find these value-based care opportunities? Where do you start looking?
Well, to give you a non-simple answer, it is a little bit less about finding and more about creating. Although we do have a model I'll talk about during the episode. Part of what is challenging in talking to OTs and PTs about value-based care is exactly what you referenced. We're not used to thinking this way and having to use data and represent spending in a way that influences behavior of those who decide where dollars go. And part of what I think kind of my mission is, my side mission in the value-based care space is to demonstrate that there is this data-driven solution in front of us and to get OTs and PTs and other, therapy professionals to start figuring out where there's a monetary value associated with their service that's not being appropriately reimbursed relative to the value it creates. And a lot of this problem is really around therapists not looking at data, the same data that plan sponsors and payers look at. So data drives value-based care, right? Fee for service, the opposite, what we're all used to. That's transactional medicine. It's based on a behavior of a patient seeking a treatment, whoever they go to, billing for that treatment, and that's it. That's the end. Value-based care looks at the inherent value of services provided and the potential return on investment. And we look for opportunities in the data where there is things like high variability for similar conditions, taking different trajectories, different paths, high variability in spending, and outcomes that are variable and that we can point to specific areas where improvement can be found. And those are kind of important concepts to consider when we think about the data that plans and payers from CMS to Blue Cross Blue Shield and Medi-Cal, what they're looking at. They're looking at opportunities you find in claims data, right, that show we're spending too much without getting consistently good outcomes. That is spending outcomes and that is quality outcomes. So let me stop there and see if you have any thoughts.
Well, I want to sort of lean on Carlin here for a second. I mean,
Please.
something that resonates there for sure with me is that there's an idea that all of us are patients at some point in our lives to somebody, regardless of what our situation is. And I think we've all definitely been in the saddle and had someone, whether it's our primary care physician or, a RN or a doctor or a surgeon or whoever, be like, all right, well, let's run some tests and we'll see what's up. And, and then 5 visits later, you're smacked with some kind of bill and it lists all this stuff that was done, but you may or may not be any closer to any kind of outcome. So I'm curious, I guess, when we're looking at, Carlin, in your case, when you're looking at like building your proposal out and like we're going to get, you have a really cool document that we're going to get to put up on the screen and show people. But when you're looking at doing this analysis on your own end, how do you run that assessment, right? Like how do you look at sort of the traditional fee-for-service expectations of the quote unquote value of care in terms of dollars for time or dollars for tests or dollars for treatment, and run that against the services that you provide as an OT in VBC?
Great question.
I know that I worded it in a way such that it was the longest walk to get to the question humanly possible. So
I think I followed.
Okay,
Alan.
great.
I want to start by saying, reiterating actually, like, this is not my zone of comfort. And so I feel like we're all learning together. And in preparation for this episode, this all is an experiment, really, for me. Feels like a draft. I'm moving through this process with the support of Dana, you too, Ellen, and like the OT Potential team. We're just kind of workshopping this all together. And so I think it's important to say that I don't know that this is perfect. The numbers need to be nuanced. There are certainly additions that could be made in thinking about all of this, but this is just kind of our first pass at what this could look like. So I would love actually to put up now the graphic that we worked on. So this is with the OT Potential team, thinking about with my role or a practice like mine, Supported Mama, working in maternal health. If this were to be provided to a client from a space of prevention, early detection, screening, et cetera, what that journey for a person might look like versus if a person did not receive preventative OT services or wellness-focused OT services, those kind of two different journeys, if you will. So on the top of this image, it shows, okay, with early occupational therapy, what the cost might be for a person. And so the rates that we have there, $225 to $1,625, that was if a person only did an evaluation. My evaluation rate is currently set at $225. And honestly, a lot of value comes from that evaluation. And very often that's the place where people get questions answered, get connected with other community resources, et cetera. And so sometimes that's where it stops. And I have really positive success stories with people that felt like their concerns were heard. They felt like they knew where to go for the next steps. And so maybe I don't work with them ongoing, but that in and of itself was really preventative, or they knew what to look for, what to advocate for with their primary care provider, et cetera. So it really did catch or prevent possible challenges further on down the road. And then it looks at that cost associated with the preventative early occupational therapy. I'm looking at like an 8-week course of care approximately. So we put those estimates at $225 to $1,625 for preventional occupational therapy. If we look at like an evaluation to 8-week trajectory of a person who's, let's say, in their postpartum journey, versus the bottom portion of the graph where it shows if someone does not have access to preventative OT and does not have access to education, potential screening, knowing what warning signs to look for, receiving treatment, interventions, et cetera, there are several different additional challenges that might occur further on down the road. So In this document, we have included feeding challenges for their infant. And so they might need additional outsourced sessions with an additional lactation consultant or things like that that might have additional costs. We have 100 to 300 per session listed on this image. Concerns related to hypertension that they might need to address with their primary care or cardiologist, and that could be up to $2,000 per case. And so I'll just list for our podcast listeners some of the other areas that we have in this image, which will be uploaded and posted on OT Potential, but concerns or additional costs associated with postpartum anxiety, depression. We have gestational diabetes. If the infant might need a helmet orthosis, could we prevent that or provide screenings related to tummy time earlier on so then an infant might not need that and the associated costs of that treatment? Certainly, we know in the pelvic health world, untreated prolapse, severe prolapse, it's much more affordable to access preventative or early pelvic health support rather than needing to go to a urogynecologist or getting a surgery to address, let's say, a grade 4 prolapse. And then some of the significant mental health associated costs related to suicide attempts and even maternal death. Which might be related to mental health, might be related to some of those cardiovascular or physical symptoms. And so when you look at an image in this way, and this was, kudos to the whole OT Potential team for working so hard on putting this together. And even seeing it again, I've seen this image several times, but seeing it again, it brings tears to my eyes when you think about what's possible with early involvement of occupational therapists, and you think about this image duplicated or replicated in lots of different practice settings, how everybody wins. Like the OTs get to provide the support and care that they love. People get the treatment, prevents these serious consequences. It's cheaper. It just feels like win, 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 win all the way around. So, Dana, I would love your thoughts in viewing this image from a perspective of, if you're putting together a proposal or trying to communicate the value to someone, how this all lands.
Yeah, I absolutely love this image. I think the visualization really packs a punch and can be used in like just like this in meeting with potential plan sponsors and network design developers. Before I answer, Carlin, can you just talk through for me what might all be included in your screening education? It doesn't have to encompass everything, but I want to make sure I touch on the avoidance potential of your kind of comprehensive evaluation and potential treatment directions.
Yes, absolutely. And I thank you for asking that, because I also want to clarify, I don't currently screen for all of the things listed on this image, but it would be possible for me to easily incorporate those screenings. So right now I provide a holistic evaluation, occupation-based, client-centered evaluation where we touch upon their daily habits, routines, their whatever goals they have, why did they seek care, what is most meaningful for them to get back to. It is very focused on pelvic floor dysfunction predominantly, but I'm asking about eating habits, movement, social activity, isolation. How their mental health and well-being is, really like what's their environment? Are they working with any other providers, et cetera? And so that's what is a part of that screening session. And then depending on all of that, we'll move forward with different elements of intervention. So each time we're setting up, coming up with an action plan, specific goals to help support them around whatever it might need. I will say that a lot of the clients that I work with, it is about helping them connect with their network, and figure out what is within their ability to ask for, to advocate for from other parts of their network, or like I mentioned, connecting them with community resources. And so it really does, it is quite variable depending upon the person and their specific concerns, but it's some version of providing coaching support, looking at their daily habits and routines, helping them integrate some of these health promoting habits in order to help them meet their goals.
Perfect. Yeah. Perfect. And this is, again, like we said at the beginning, this care type, the intervention that you potentially can have, has such a big impact because of the multiple variables that you're looking at. So you're looking at early detection of declines in mental health, physical health, sleep, all of the things that you have the ability and the license to be able to evaluate and monitor. You can intervene early and prevent a host of not just downstream impacts that you and your coaching and treating can help to prevent, but your ability in your interactions with the mom and baby are able to identify issues that do need the support of additional professionals. And in the value based care space, we like to think of that often as care navigation, care management, care coordination. All of those things they're so perfect for therapy professionals because skill sets of therapists are really around helping connect with individuals, helping coordinate care of individuals, helping to engage them in their care, communicate with them and with other professionals. And what we know about traditional medicine is it's often missing these things. It's often missing the ability and the time and the background and the structure of care to have an impact on a lot of what takes time and coordination of care. And so it's kind of that three-pronged approach: the treatment that OTs, treat and the impact that you have, the early identification and the oftentimes needing to co-treat or to refer for early support, and the ability to support care navigation. And so I'm going to get to below the line in a minute, but as we talk about workshopping this, I see a lot of opportunities around episodes of care, which is kind of a buzzword again in value-based care. But the comprehensive set of solutions that an OT can create with their skills and knowledge right now, right here, right? The ability is already there, and knowing the gaps that are present for many different payer types, and they, without having good solutions that they're aware of, we have the ability to pitch the solution. And I'll say one more thing about the aware of, because I think sometimes therapists miss this link and it's valuable to know about. OTs and PTs, we do a pretty good job among ourselves and in some promotion outside of ourselves into the public of what we're capable of, what our outcomes are like, and what our value is. But it doesn't mean that physicians and payers are paying attention to that, right? They're paying attention to the things that they hear about all the time, that's brought to them all the time, they're surrounded with. And they're not surrounded with, or come in contact with, or have the incentive that they know of, to know about solutions that an OT can bring that address their pain points. And so that's part of the having to advocate to the right people in the right places, and why this is a path. It's a journey. It's not a do this and then you have a contract in place. I wish it was so simple. But the awareness of what's required is part of what will allow OTs to make a dent in this. And you absolutely can. It's been done before by, providers like behavioral health providers. It can be done, and I am confident it will be done.
I would actually love to drill down just a little bit deeper into that thought because, like you said, when it's laid out like this, and I can imagine bringing this to a network or provider or whoever and being like, I mean, what's that phrase? An ounce of prevention is worth a pound of prevention is worth 100 pounds of cure, I think is the phrase.
Perfect.
But, like that makes sense. That's so easy. Like this graphic in particular that shows the comparative costs of like all these potential issues that we can screen for early and or avoid altogether. What's the easiest way to fix a broken leg? Don't break your leg. Like it feels so obvious. So I guess the question then to drill down into what you're saying about like how and who to bring this information to, what does it logistically look like to take a proposal or even something like this? It's just like demonstrative document of some kind. What does it look like to actually take that and reach out to someone with it?
Great question. So you want to first think about who already recognizes that there's a problem and has the incentive to find a solution for the problem. That's going to potentially look different depending on the condition. The two that jump out at me when I think about postpartum care, the two highly incentivized types of organizations, like I said before, are going to be those employer sponsored health plans and Medicaid managed care organizations. I'll start with the first. When we're thinking about employer sponsored plans, the way to kind of get in the door that many take when they think about offering a unique solution is meeting with brokers, benefits consultants, HR leaders, benefits managers, though human resources, those folks at organizations that employ a lot of childbearing age women have an incentive to find ways to control their spend that's variable. And I promise you, they're looking at the data around these areas around postpartum care. And when you bring a solution that solves a problem, you have a much greater chance of them being willing to work with you on putting together a specific, what they call like a network design program, or a novel contract where you come up with, it could be a very simple proposal where you're offering early access, you're offering, let's say, as an example, one bundled payment cost where they're providing that cost, you're providing whatever care is needed for the dyad, the mom and baby, and you're offering to support things like care navigation and coordinating care, right? And making that data driven picture very clear, even going a little further than what we designed, but really calling out, doing the next level research, calling out what employers are often trying to solve for when it comes to maternal health, right? You think of costs that are not well controlled because moms don't have access, extended maternal leaves. Those two factors alone are incentives to find new ways to manage this population. So there's that. So that would be kind of looking at the HR areas, brokers, consultants, those that are having those conversations with plan sponsors. And then on the other side, this is already an area where there's a lot of attention being paid, are Medicaid managed care organizations. About half the births in this country are those on Medicaid. And there is
Wow.
an even more, it's a big number.
Yeah.
And there's an even more accentuated problem with finding enough access to care beyond the day of birth and that 6-week checkup for the mom, and potentially the pediatricians picking up on something. But when you think about pediatricians and OBGYNs, do you think care coordination? Do you think spending an hour engaging with you, right? Engaging with your, listening to you and getting you to kind of bring out what the issues are that are developing? I don't, right? Pediatricians are great with preventative care. They're the kind of trailblazers, but they're generally not spending a lot of time and don't have the time to really dig into a mom that they see deteriorating. And those gaps aren't filled well by any one organization right now. The numbers, if you ever want to dig into them, they're astonishing. There is right now a novel program that it just launched, what they call the pre-implementation stage. It's called the Transforming Maternal Health Model. It's in a CMS Innovation Center model, so the Center for Medicare and Medicaid. It's an innovation center model for 15 states, including California, for the state Medicaid agencies to partner with Medicaid managed care plans and providers of all kinds and community-based organizations, essentially being given a substantial grant to develop unique, innovative ways of getting the quality to improve and the costs to be brought under control for managing specifically maternal health. And that model, just launching, 10-year model, I mean, to me, that is the first opportunity I would begin to look into, knowing that there's this great need. So let me stop there because I'm sure there's questions.
Yeah. I mean, something that I found interesting from that answer that I think is well, it's useful to me, like I hopefully useful to everyone listening as well, is I think potentially one of the things that feels like an obstacle in pursuing this is feeling like you have to have it all done and like laid out before you even talk to someone or make the approach. But from what you described, it sounds like it's possible to, develop the programs with the people that you're bringing your proposals to, which takes, I imagine, some of the stress or pressure off of this idea of like, I have to be able to go in there and be like, this is A, B, C, D, E, take it, leave it, negotiate from here. But I think that idea that, yeah, we're coming in the door offering a solution to a problem that already exists is, I mean, who wouldn't want that, right? Like you don't have to push super hard. I imagine to work from that angle. And since this is also data driven, I'm going to direct this question at both of you, I think. And this actually partially comes from one of our commenters in the chat, Sarah, was saying, I can't stop thinking about how little data we actually get access to as therapists. I'm so curious how we can see the same data as our payers. So we're talking about approaching something like VBC from a really data research driven side. Where can people who are interested in pursuing this or looking into this find the information that they need to build their proposals and analyze the benefits of their care and like break down the analysis of their costs? I mean, where did you go, Carlin, and what other places or did you?
This is where I really had a lot of support with, the OT potential team, because that would be my question. It's like, where do you start? And I think, this is going to be like an additional question in the answer, I guess. But I think, like, as we're talking about all of this, it feels so big, and it can potentially feel very overwhelming, and especially speaking from the space of being a sole proprietor. And I'm thinking about my days where I'm trying to do like my marketing and then, client care and documentation and, all of these pieces. It's like, where do I fit this in a way that is feasible or something? And so then I'm imagining myself, I'm here in Sacramento, and do I march on down to the Department of Medi-Cal here and say, here's my idea, and do we work together on that? Or like, do I shift to, I'm thinking of a local practice, a women's health practice that has 6 OBGYNs, and I get referrals already from some of them. And is there a version that's like a scaled down version where it would feel a little bit more comfortable to be collaborative and share, okay, this is my partial data that I have. And to answer your question, Alan, it was evidence-based review, kind of quick lit search on cost effectiveness of certain treatments, et cetera. And so, we really put it together quickly. And so might there be more data that could be included in there? Certainly. These were some of the articles, though, that stood out. And so one of my mottos around all of this is, don't let the perfect be the enemy of the good. That's like the way I have to operate as an entrepreneur with also a role in academia. And so it's like, let's just get something together. And then let's reach out and get the feedback around all of it. So that was part of my process. But I am wondering about how to move forward in this for all of the people who might be listening are like, I'm not going to go talk to Medicaid. Like, how do I do that as an entrepreneur in like little bite-sized chunks?
So great path direction for the questions, because I think we have a chance to really clarify that, yes, you're right. You don't have to start big and huge, and you don't have to have access to all of the data to begin a partnership with a payer. The way you can think about it is, your first partnerships with any payer are generally going to be simpler, right? If you don't have access to the data they have access to, and in most cases you're not, although we can talk about how providers generally get that data. When you don't have all the access to the data and you're going in to have a conversation to align on what makes sense that I can move the needle on and prove myself so that they can see the results in their data. That's where it would start. If you don't have access to, these are the exact opportunities that I see. if you point out where they can find the opportunities, they can look in their data. So for example, if you're talking about, let's just stick with mental health because it's such a big fish here. If we talk about maternal health and the impact on cost and quality for women who suffer from postpartum depression that is not resolved, and other impacts, including all the way up to attempted and successful suicide, unfortunately, if we think about that, that kind of data is going to be available to a payer. They will understand what their mental health related spend for postpartum moms look like. There's a triggering event. They're going to see the interactions that they have with the healthcare system, which will usually be downstream. They're going to see their pharmaceutical transactions if they're filling prescriptions to treat depression. They're going to have an idea, and you can telegraph the types of treatment that a typical patient might have, right? Who has postpartum depression, just as an example. And so what you're going to be doing early on is saying, here's the evidence, and keeping it very simple. Here's the data we do have about the impact of OT on postpartum depression, postpartum mental health, reduction of suicide attempts, et cetera. And you're going to propose some kind of relationship with them. And after that first period of time, probably a year, they're going to look back at the data and see if it did make an impact. Part of that negotiation is needing to be a networked provider that has a good rate, and you're going to have some volume so that you can evaluate whether or not, with a high enough number of patients, you can evaluate that impact. So these are their negotiations, and starting small with a local plan or working with others who are interested. And what you brought up about OBGYNs is bigger than I think you even knew when you mentioned it. There's lots of OBGYNs who are being made to get into value-based contracts or are being offered value-based contracts that they want to participate in, but they don't have the ability to pull the levers to be successful. And those kinds, OBGYN value-based models will often look like the expectation that the OBGYN practice is able to provide a higher level of support to reduce the negative sequelae of events from complications and everything else that can happen in the dyad postpartum. Again, they may not have the resources internally, but you can propose to them these resources as an OT who's providing this comprehensive care. So that's one way to think about it. I can talk about the bigger data picture, but I want to stop and see if there's questions.
Yeah, I think, Carla, unless you have any questions on that, I just want to make sure we're reserving time for some of the questions we've gotten in the live chat of the webinar as well. So I'm going to do a rapid fire question for Dana here, which is just like, basic overarching bullet points. If we're moving from this proposal phase into developing or building our contract, what should an OT consider in the actual contract? Like what should be there, what has to be there, at the highest level.
So if we're talking a first contract with, I'm going to suggest an employer-sponsored plan is going to be the easiest way to go. The first contract, you're going to have certain asks of what you would like in return for your services, to keep it super simple. And you're going to back up those asks with, if it's not your specific data, well-established data about the impact of OT. It doesn't have to be perfect, but it has to be something to demonstrate the impact you can have. And you're going to be looking for a way to partner that may seem like it's relatively simple, but it's a way to establish that relationship. And like anything else where we're looking for making big change, it starts with relationship building trust, and with a data framework. Value-based care is always going to be on a data framework. So let's say one example might be, whatever it is that would be the established cost for, let's say, a single visit for an evaluation, a comprehensive postpartum evaluation, coming up with a number that sufficiently supports that evaluation and takes into account the spend that you're potentially preventing. And you're going to be relatively conservative with that prevention because nothing else will be believable. Plans are going to look for something conservative. So you stick with a couple of the biggies, right? Some of the big rocks around mental health and around pelvic floor, things that like plan sponsors are more likely to be thinking about than other things. And look at that avoidable spend and start by offering something like putting you in the network for postpartum care. How that might look, we'd have to talk through further. And this would be the reimbursement that you would expect. And it would obviously be significantly higher than past reimbursement. And maybe you stop there with the evaluation for the first go around to keep it really simple. Or maybe you combine that with a care navigation package and follow-up visits of a certain number that you bundle into a payment. They offer it as a benefit to their employees. And then they're going to carefully track, as are you as best you can, the data that supports the success of that first initiative. So to Carlin's point, and I'm sure lots of listeners, don't let the overwhelm of how big this could be stop you from taking the first step, and be realistic about how much progress you can make in how much time.
Yeah, it feels like
Does that help?
I think that's a really good way of putting it too. And reiterating again that if what you're offering is a solution to a problem, they want to be in on the conversation.
That's
because,
right.
You know what I mean? Like they'll have things to add and to that they'll tell you what they need and want because you're already providing something for them.
Plans are just one more additional thing that I think is valuable to know. And I know, I have plenty of experience working with plans. They look for solutions to their variable high cost spend. They look for innovative solutions. You have to think about the types of payers that are going to be looking for innovative solutions and be broad about that thinking. Again, I'm thinking we're talking Medicaid MCOs and we're talking employer sponsored plans as like the big eggs here, big rocks. And think about what they're solving for. Plans want innovative solutions to big problems. It makes it easier to develop a solution and get a contract in place when you know what they're going to care about. What's the data look like? What is this going to cost them? What potentially can we see a benefit in? And then start something and then revisit it in a year and see where we are.
Great. I think we're going to rush into our Q&A here just to make sure we address some of the comments. I've been seeing stuff come through. I'm always excited to have people participating live in these webinars. So we're going to ask some questions directly from the chat, starting with this one. We sort of talked about it a little bit, but hoping we can expand on it, specifically because we talked about mental health as it relates to specifically like prenatal and postnatal care. But is a value-based model feasible for a private OT mental health practice? And if so, how? This is from Meryl Gilbert.
Absolutely. Feasible could look a lot of different ways. Feasible in that you have the license that allows you to support that type of medical problem. Feasible that it's a solution that there is no solution for this big scope of the problem. 100% feasible. It's a really starts with an access issue. And that lack of access, it's keeping it super simple. Lack of access causes progressing of a condition, and then people end up in the hospital. And essentially, anything that you can propose that prevents hospitalizations, and there's plenty of documentation to support this, anything you can propose that prevents a hospitalization is worth 10 times whatever they're paying for it. It's a matter of presenting this in a factual, data-driven way from what we know and have evidence to prove that makes the case. Behavioral health is an easy place to start because there are just not enough. There's nowhere near enough support and quick access to care.
Yeah, I mean, I feel like it's a known entity that it's just a giant, right? And bigger even than the amount of people seeking care, because again, there's so many limiting factors and barriers in the way for people who oftentimes need it most. Carlin?
Can I piggyback off that? I'm just curious, Dana, off the top of your head, are there other areas of practice that you really feel like are ripe for this model? You know, just like off the top of your head, what are some things that you think of, like you see this really, you know, picking up steam?
Absolutely pelvic floor, without a doubt, because it is a known entity that is already showing value in different populations and being used more and becoming more commonplace. Why don't we play a little game of tell me some of the things that you find are the biggest issues, and I will give you an assessment, if that's okay, of what I think about that in the value-based care space.
Gosh, I mean, so of course, you know, the area that we've been discussing was top of mind, but along with mental health, which you've already stated, I think a lot about wellness. So some of the lifestyle medicine, lifestyle redesign types of practices, and so there's like prevention and management of chronic conditions. So like chronic pain and lots of other, you know, chronic conditions. Those are the things that my brain goes to immediately. I'm curious if anyone else in the chat has other practice areas that they're thinking about. And while we're here, I'd also like to say that if there are OT practitioners who are listening to this or know of, you know, colleagues that are already working with value-based care models, we would love to hear about, you know, how you have it structured, and so we can learn from you and grow our profession together, because it really does have such amazing possibilities for it. So
yeah, I'm already actually seeing some areas of care being suggested in the chat to go along with the ones you mentioned, Carlin: home assessments, post-stroke, dementia,
sleep. So I'm sticking with, I was thinking children, but there's sleep, maternal, not children, sorry. But yeah, sleep, not just sleep of the mother, but sleep, things like sleep training. If that's within scope, that's absolutely something that moms need help with, and it impacts their own mental health when they can't be successful. All the lactation, any lactation work, there's not enough lactation practitioners either. So where that can be supported. If you talk big broad OT, there you could go down lots of different directions. I guess I would point certainly to the guiding and an improved dementia experience model, the guide model, a large dementia model where there is a call out specifically for OT professionals to be contracted and even to run the models. And then there's a model that's launching in January called the Transforming Episode Accountability Model. That is an acute episodes of care model where you're encouraged to discharge patients to the home, and a lot of times there is support needed by OTs and PTs. But that's I mean, we could go a lot of we don't have time for it today, but we could certainly go down a lot of rabbit holes on all the areas OT could be involved.
Well, maybe we'll do a special 2-hour extended episode.
No, we're planting seeds for future episodes. I mean, I really see us doing more on this, because it's
I mean,
really exciting.
it's weird because at its most basic, I guess most things are at their most basic core concept pretty simple. But in terms of the scope and possibility of execution on value-based care, it's like there's so much potential there. There's so many ways to approach laying out proposals and going into different areas. And yeah, you're right. You're right, actually. Yep. 500 more episodes of this.
It's a culture shift. It's a huge culture shift. You cannot minimize how hard it is, but it's an inevitability. There is no other solution for getting control of our health spend, and OTs need to be a part of it.
Well, actually, the next question I was going to pull from our chat kind of piggybacks well off of that, because I think on the individual level, like the culture shift is like this big paradigm thing, and like it's out of our hands. It feels beyond us. But on the individual level, we're all going to play some sort of part or be ahead of the curve or catching up, or something's, you fit somewhere in the wave, right? You're a particle in this giant wave.
Mhm.
That's a cool analogy, huh? Um,
Yeah.
so in terms of initiating a start on this, we got a comment or a question from a commenter in the chat. How would you suggest, this one's directed to Dana, but I think either of you can and should answer this. How would you suggest initiating contact, in Carlin's case, with a local OBGYN? Is it as simple as just getting coffee? Does it need to be more of a, like, pitch,
Mhm.
like a formal pitch
Can
or
I offer like what I'm thinking?
yeah, I think that's why I was
Um,
like, I think this question is just as good directed towards Carlin
yeah.
because you have a network in place of some kind, right?
Yes.
Yes. So I do have, this provider within the practice who regularly refers to me. And I am leaning towards inviting her for a coffee where I can just talk about this with her, just all of this, this conversation that we've had, this episode. I'm curious if her practice is already incorporating value-based models in any of their work, and just kind of brainstorming possibilities with her alongside her, highlighting what she knows and what she sees within her practice is that people aren't getting the care. She can't provide the care that she wants to, given all the constraints we've, alluded to. And she knows that she wants her people to get more access. And so I think she'd be very open to having that conversation, and we can collaborate on what makes sense within her practice. I recognize that not everyone is already friends with, somebody who happens to be in a provider. And so I feel like I'm a person who's like a cold caller, like a cold, like a reacher outer to just say, hey, I would love to connect. And so yeah, that's how I think I would approach this on an actual logistical level for me and where I'm at in my practice. That feels doable to me. What are your thoughts about that, Dana?
I think it's perfect. And I'm glad you answered first because it got me thinking about what opportunities might be knocking on the doors of these docs. And OBGYNs are very likely going to get tapped for the TMAH model, they call it, the Transforming Maternal Health Model. They're going to be tapped, and they're going to need solutions to participate that are going to go beyond what they can do themselves. And not just that, the Transforming Maternal Health Model, Medicaid organizations increasingly want to get control of things, again, high variability, have the potential to have a lot more value created. And so you can actually do a partnership, create a partnership with, an OBGYN practice you have a relationship with. You be willing to be a direct partner in standing up this model. Medi-Cal is one example, but you could do it with any commercial payer or an employer sponsored plan, right? And be willing to be their direct partner so you become a team and you both have incentives to participate in whatever ways you decide. For you, it would be if they're going to be the physician taking risk, you're going to join them if they're and I don't want to go down the risk path, but essentially there's a lot of upside potential to earn higher dollars as a practice for physicians. This is common how they structure. You can join them as partners in a model and figure out what parts of making that model successful you're going to own, and then work with the physician practice on where's your upside? What does your upside look like? And so you establish that relationship, work with the physician on a contract with a or more than one payer, and let them help you. They are going to have additional resources that you won't have access to, likely, to make it a little bit easier, and have lots of other ideas, can share with you things that have been pitched to them already by payers. So I'm so glad you brought that up. Perfect.
Yeah. Dana Strauss, thank you so, so much for joining us and talking about value-based care and why we shouldn't be calling it that anymore.
I still do. I can't help it.
As a reminder to everyone in the chat and also those of you listening, make sure you use the link to take the post-course quiz in order to get your CEU credit. And thank you as well to Dr. Carlin Reaume for being here, answering questions, asking questions, sort of letting us guinea pig this model on her own practice. It's been really cool and eye-opening, and I'm sure we will have many more conversations about value-based care here at OT Potential in the future. Thank you both so much.
Thank
Thank
you.
you.
Really fun.
Take care, everybody. We will see you next time.
Thank you for joining us on the OT Potential Podcast. To earn 1 hour of AOTA-approved continuing education for your time today, you will need to sign in or sign up at otpotential.com. Once you're in the OT Potential Club, you will find a 5-question post-course quiz connected to this episode. When you pass the quiz with a score of 75% or higher, you will be able to download a PDF certificate that certifies your completion of this course. Okay, I want to thank you for joining us today, and we'll see you next time.